Let's roll. Welcome everyone to another wonderful episode here at Jaws Podiatry. This is a very, very great case for a lot of great reasons. The infamous, notorious Morton's neuroma. That's what we're going to talk about today. Again, Morton neuroma. We're going to hit the whiteboard today. What exactly is a neuroma? Just to keep it very, very simple, it's an enlargement of one of the common plantar digital nerves. Foot, toes, metatarsals. 1, 2, 3, 4, 5. We have a young patient who has been battling a tremendous amount of pain to the location of the second interspace. Whether the second, third, historically second and third, that's where you kind of see them the most, 2 and 3. You may develop and again, we're not going to go into the whys. You guys can Google that. The patient has developed a Morton's neuroma. Tremendous amount of pain, 9 out of 10. The patient has other medical issues that we must take into consideration, but we tried, we'll just say all conservative treatments, which I like to call the Band-Aids, and I think today is kind of like the tipping point. So there's one little procedure that I dearly love, the percutaneous release of the deep transverse intermetatarsal ligament. What did I just say? I shall explain. Metatarsal, this is number 2, 3, 4. The green is the ligament. The ligament is what holds all these metatarsals together. The black, the nerve. This is normal. This one is not. So a normal nerve looks like this, right? It goes underneath this ligament, and then it splits into what we call these tiny little bunny ears. And one of the branches innervates one toe, and the other one innervates the other toe. These are sensory nerves. Way back when, in the good old days, when I had this similar clinical presentation, I was just telling the patient that I would recommend excision of the neuroma, right? Just take it out. But, I quickly learned that wasn't really, sometimes it was effective, sometimes it wasn't. And then, I didn't want to compromise, number 1, the nerve, and number 2, there's another complication that could be very detrimental, which is what we call a stump neuroma. Extremely painful. But nonetheless, I quickly started implementing the percutaneous release of the deep transverse intermetatarsal ligament. This is the ligament in green. And make believe, right now, the metatarsals are basically like this, right? Really close together. And what's happening is that the metatarsals, when there's movement, the metatarsal heads are crushing the nerve. And that's when the patient feels these, numbness, burning, tingling, like when you hit your funny bone. So what we basically do is I make a tiny 1-stitch incision right on, and I'll show you guys on the foot, right around this area. This is the top of the foot, by the way. We're looking down on the foot. And basically what I do is I just release it. The minute I release it here, okay, this metatarsal will move this way. This metatarsal will move this way. So these metatarsals are going to go like this. In this particular case, again, the black is a nerve, and then it looks like a balloon, like a cocoon. And every time this and these 2 metatarsals move this way, that's where the nerve gets impinged. So the idea is basically to separate these 2 metatarsals. It's an extremely effective procedure. In other cases where, we also implement, which we're not going to do in this particular case, but I'll go ahead and just mention it and I'll put it out there. We also cut the bone here and here. It's called an osteotomy, in order to really maximize, right, depending on the size of that nerve, to really maximize the improvement and minimize any long-term complications. So that's something else that we also do. Let's take a look at the foot. So again, sorry about this patient. So metatarsal, metatarsal. The metatarsal head is here, the nerve comes here, and then again, this is where the neuroma is basically just located. What's the blue dot? That's where the incision goes. One little stitch, boom, go down, identify the ligament, and just simply release it. Dr. Wagner, that's all? Yes, that is all. Nothing more, nothing less. Sometimes we even put a little a little bit of PRP. I may decide to do so. And that really helps with the healing process. Just like that. But Dr. Wagner, don't you need that ligament? In this particular case, not necessarily, right? Sometimes you'll see a little bit of splaying, which is exactly what we want. But, during the course of since I started doing this procedure, I've noticed that, patients have been extremely happy with the outcome. A lot of surgeons out there, will quickly recommend excision of the neuroma. Surgery. Big incision on the top, excise the nerve, and that's it. Call it a day. I think there's a time and a place. But, when we put the puzzle together, I think this would be, and will be, an excellent alternative. When we talk about minimally invasive, people say, oh, minimally invasive bunion surgery, minimally invasive hammer toe surgery. In this particular case, it's minimally invasive neuroma surgery. People don't know, and that's our goal here. We will continue to educate the whole world that these procedures do exist.